Thank you. Good morning. As we open our June Board of Health meeting, which is being streamed live on Facebook, do so with a moment of silence for the victims, families, and friends of those in both Buffalo, New York, and Uvalde, Texas. May the thoughts and prayers of this entire country translate into actionable policy and change. Moment of silence. Today's meeting marks, if you will, a quote, peaceful transition or beginning of next gen public health in Louisville as we head toward the end of the Fisher administration. A huge shout out to the department's team for a meaningful and festival send-off celebration in honor of Dr. Moyer's 8-year acclaimed leadership. Along with the mayor, I was proud to toast her exemplary achievements. She has over-earned some time off as she prepares to, if you will, cross the sector divide and enter the private sector. We welcome Dr. Jeff Howard, current interim director and the city's chief medical officer, who is finishing his surgery residency at the University of Louisville. A lot to celebrate for him and for his family. More about Dr. Howard in a moment. We also welcome Taylor Ingram, longtime department member, as Dr. Howard's chief of staff and the department's representative or liaison with our board. And we welcome Arlena Glenn as Dr. Howard's administrative assistant. We are truly dedicated and indebted to the all-knowing Amanda Clark for her dedicated assistance and support for our meetings. And taking a point of personal privilege, I salute her perseverance with this obsessive compulsive perfectionist with a strong bias for action and work to be done at warp speed. So a couple of action items which, due to the fact that we have people out ill and otherwise not here today, both will be deferred to the next meeting. Those would be the minutes from our May meeting, as well as an action item that was sent to you regarding family health centers improvements that they are making to their site in Portland. We will consider this at our June meeting. Moving on now to the perspective session. Today's speaker is Louisville Metro's interim public health officer, chief strategist, whose work in public health and the national and state levels are well respected. Dr. Jeff Howard hails from Harlan County, holds a master's in public health from Harvard, has served both as a White House Fellow in Health Policy for a previous Vice President and as Kentucky State Public Health Commissioner for 2 former governors. With a medical degree from the University of Louisville, I haven't had enough coffee, he is completing his residency in surgery and is in private practice. He holds an MBA from Northern Kentucky University. His wife is principal of Bullitt County Elementary School, and they have 2 young children. He's definitely a leader with a bias for action, as evidenced by the publication materials that he sent to the board members as a pre-read. Dr. Howard will briefly overview his strategic priorities, focus, and agenda for the department, the board, and the community. He'll also share some changes in the department structure. I will open the floor for board interaction following his comments. And as they say in the Kentucky State Legislature, Dr. Howard, this kind lady from the county of Jefferson yields the floor to the kind gentleman from Harlan County.
Well, thank you very much. That was an introduction that was far too kind. Let me make sure we're ready to go here and make sure we're good. All right. So forgive me if I stand while I talk and address the room.
Okay.
We're
I think
good?
they
Are we
can
picking
hear
up? Good.
We can hear them loud and clear.
All right, good. So I'm going to try to accomplish a few things. One, I'll move past the personal introduction quickly, as Heidi done that very well for me. Thank you, Heidi. And then we're going to move in to talk about what public health transformation was in Kentucky. I want you to understand, I think it's important for the board to understand why Kentucky needed a public health transformation and why nationally we need public health transformation. Then I'm going to spend most of our time talking about that. Then I'm going to narrow down what that looks like at LMPHW moving forward. I think at the end of this, you should understand public health transformation well, why we got there, and most importantly, how we would frame the future of public health here in the local metro area based on that. So just briefly, as Heidi told you, I grew up in Harlan, Kentucky, which borders Virginia. If you go down just a little bit further, you reach the Tennessee, Kentucky, Virginia border in the Middlesboro area. I went to public schools both in Harlan and Buck County, so I claim the whole region as well. I never thought of myself as much an academic. In fact, thought I would probably join the coal mines like most of my family members. But in order to keep playing football, I made a big jump to Union College, which is in Barberville, Kentucky, about 20 miles down. And then from there, after a knee injury into my football career, decided I better do something different.
Oh my gosh, what a story.
Who was that? Oh, thank you, Leanne. Decided to come to go to medical school, and mostly because I got involved in a free health clinic as part of the Honor Scholar program. And then stayed here to train in general surgery after. That was in 2014. And then here's the point where my career sort of took on the face that's sort of reflective of who I am now and who I see myself as a professional. And that is kind of a chaotic mess where I decided to do a bunch of things at once. So at this point, I went to serve with our state government at the Cabinet of Health and Family Services as our Commissioner of Health and Chief Medical Officer for the state, which is a job I had no business doing in 29 with no experience, but I decided to take that on. I went up to Boston to do an MPH and went up to Northern Kentucky to do an MBA. I did all those at the same time, which was an absolute blast, and my wife loved me. After that, I spent a year in DC as White House Fellow, leading health policy for the Vice President, which was fantastic. I was there through COVID, got to see public health and affect public health policy at the national level. Then came back home and finished my training here, which I finished in a couple of weeks, and then we'll be joining North full time or part time actually. My wife Brandy, who you mentioned, the principal of elementary school. Our son Jeffrey is 7. He would be mad if I didn't tell you he turns 8 next month in August. So he's 7 point, be like 9 or something, whatever he calculates. And our daughter Kate, whose front teeth are now coming in. This was it. So moving on to public health transformation. Why did we get to where we need a transformation? And I'll tell you, it wasn't just, hey, I'm a new leader on the block, I want to do something new. It was because we were financially completely unstable in our state's public health system. Okay. And I'll go through the details of why that is, but the whole thing basically was imploding under my watch back in 2017 going into 2018. And we found that when we did our analysis, up to 42 of our local health departments, we have 63 health districts in Kentucky, 42 health departments were at risk of financial default. And that was in 2020, so about 2 years after this. And we found that our annual deficit was going to be about $40 million. This is a system of about $500 million. It was actually about 560 at the time, so it's a pretty big deficit. But I will tell you that about 250 million is federal funds, so only 250 are relatively flexible funding that we can move around. So you're talking $40 million deficit in that $250 million fund. So not a lot of flexibility. And then here's the most important thing is when I surveyed our system, I found that the current dollar flow didn't match priorities. Rather, how it sort of worked was you'd have federal funding. So federal funding would come down from the CDC in terms of a grant. That grant would then say, okay, you have to do X, Y, and Z service. Maybe it's do a breast clinic, maybe it's do a colorectal screening clinic. But it also didn't fully fund the program. So either the state put in some money or the locals put in some money. Usually the locals were on the hook. The state may or may not contributing. And what that meant was all the flexible dollars we had here at our local health departments was garbled up and obligated by state, by essentially what the state had deemed from federal funds. Does that make sense to everybody? And then when I looked at where's our greatest deficits coming in the system, where are we losing the most money? It was in clinical services. So outside of what I thought was pertinent public health, it was doing the things that your doctor should be doing. So here's what that financial analysis looked like. I told you 42 of the health districts were at risk of default. Red counties were within 12 months, and the yellows were within 22 months. Okay, so it was bad. So when I took this map around and showed it to people, when I spoke to the legislature, everybody was kind of appalled and realized we had to do some action. And I want to tell you about how we ended up there. And there's really two big changes that happened in the modern era that led us to this point. One was the Patient Protection and Affordable Care Act. That is not a knock on the ACA. I don't want anybody to think that I come in here and say the ACA is bad. That's not what I'm saying. But in terms of public health, it changed the game. And so before ACA, at least in Kentucky, a lot of indigent care was done at our health departments. Okay, we were the first medical center home almost for some people. We had robust pediatric clinics. We were doing robust colorectal screening programs. We were doing robust women's health programs, where we were offering women's health almost across the spectrum. And many of our health departments employed NPs and folks who were doing almost OBGYN type work at our health departments. So it's almost understated across the country. And I don't think a lot of people realize the effects the ACA had on healthcare. I think overall for patients, we're better off to have medical homes. We're better off to fund the Family Health Centers of America and our rural health clinics. But it just changed the game and shifted what the patients seek in indigent care. And then Kentucky's pension crisis, can't understate this. This was the talk of the town back in 2018, 2019. I'm sure you all remember. And y'all remember we are the quasi-state entities. Now, LMPHW, Lexington are a little different because we're not in the state pension system. But to think this didn't affect us would have been malarkey. It certainly did. But when I looked at it, I said, you know, despite money and everything else, we're still 45th out of 50 states. Our overall healthcare is poor, and we're not really moving the needle at all.
So what's that measuring? 45th out of 50?
Yeah, so this is America's Health Rankings.
Expenditures,
This measures, so this is America's Health Rankings, and it would have to do a whole presentation on what that is and how they do it. But essentially, they take some health categories and they rank states based off,
okay,
how
so
they.
it's health, it's not like
Yeah.
spending per capita.
Actually,
Let's do this, Taylor, if you don't mind. If you'll Google it and give it. Now I'm going to try to. Well, actually, Marlena, we can send it out with my post meeting note to the board because they produce this regularly and it's not pretty. It's not anything that our own Center for Health Equity report healthy Louisville 20 whatever year we're in. It's the same thing. The ranking is the same.
America's Health Rankings.org, Taylor.
Yeah, it's actually the best.
Yeah. So you look, click ahead. And then you look back to 1990 and it's been bad for a long time. And we sort of, only time we really go up or down is based off when they make tinkerings to what they're measuring. So we didn't really see any sustainable health change over that time period. Now this is confounded by huge numbers of issues, a baseline sick and ill population, et cetera, et cetera. But no one can argue that we were doing a great job, that we were making any progress. When I looked at the system, there were really 4 overall challenges. I won't spend your time going through all these, but we've already talked about the programmatic services not meeting local public health needs. Talk about how that's driven largely by federal funding. There were some legislative issues that we have to overcome because the way public health law was written at the time was a major issue, and we had a attorney who was actually my chief of staff at DPH, Dr. Kelly Alexander, who headed up a lot of this work in conjunction with some folks at the University of Kentucky School of Public Health, who worked in a long place to help us categorize our public health laws, understand what they were, how we can update them, and most importantly, get a law passed that allowed us to make the changes we felt. And then finally, Kentucky adopts what's called a shared governance model. And I'll talk a little bit about public health models, but it makes it a little bit difficult to make changes across the board. I'll talk to you about it. But I wouldn't be me if I could say, okay, yeah, there are problems, but there's got to be some solutions. So here was the solutions I proposed to these. Physical instability, we had to simplify and focus our public health model. We had to prevent duplication, share resources. We had to knock down the boundaries and silos that we've created with these public health districts. We had to work across those districts as we needed. We had to create economies of scale. We had to ensure we had fees to cover that matched our costs, because we were doing a lot of things for under cost. And no offense to this board, but other boards would say, hey, we're going to do a service for the school district and we'll offer these services below cost, and we just could not do that to maintain. And you would be surprised how often that happened across the state. We had to create prioritization because we couldn't do everything. Couldn't be everything to everyone or do everything for everyone. Then use of contractors where we could, because contractors in public health and in governmental space ends up bringing a lot of value for the buck and give you some increased flexibility. We talked about programmatic services, and I'll talk to you a little bit more about how we address that. Legislative issues, we just had to fix them, and that means get buy-in from the legislature to change laws, which isn't easy, but we accomplished it. And then for our fair governance model, I'll talk to you here about what that looks like. Really, three real governance models in this country for public health. You have centralized, where the state controls everything, central. Decentralized, where the health departments control their own mission, their own goals, how they spend their money. You have shared governance, where both the state and the locals share governance of the public health system. That's where Kentucky is. And then there's these mixed models. We sort of live more in the shared governance space. I will say Louisville Metro and Lexington have a little more autonomy comparatively to the other areas in the state, because with that pension plan comes a lot of control in the state. Okay? Because where the money goes is where who makes the rules, right? So mom and dad make the money, they tell the kids what to do, and that's sort of what happens. But just so you know, that's sort of how it works. So what do we come up with to solve this problem? How do we focus our priorities and give a framework with which health departments could work? We come up with what we call core public health. And ironically, if you Google this today, there's a state website for this, and they're still working on some of the details. But they still use this slide that I'll show you, which I find hilarious, because I wrote this on a napkin at a meeting with the governor's chief of staff, and I went home and made this PowerPoint slide. And I'm not a graphic designer, so it seems like they can pay some $100 to make this look. Anyhow, so there's nationally what is recognized as essential health services. In Kentucky, we call those foundational public health. And those are things we have to do. They're required by law. They're written in statute. We have to do them. These are things like restaurant inspections, et cetera, et cetera. There was three other things that I felt were essential to Kentucky public health. Because I had the pen at the time with the ink in it, I added these in. That was our WIC, Women's Infants and Children's Program, our HANDS program, and then our harm reduction and substance use programs. We'll provide you a copy of all this. And so these are things we have to do. So the language I use and the language in the statutes with the health department will do or ensure these services. Okay. So a lot of these services we insure here at Louisville Metro. We do pretty much all of these, but we insure WIC, meaning we have some partners outside of our agency who offers WIC on our behalf, which I'm totally fine with, but we're ensuring that those services are available to the folks in our community who might need them. So that makes sense. Then the extra bucket, whatever is left over, is our local public health priorities. And what we really wanted to do was make sure that the health departments were doing the core stuff first, and then identifying priorities that then they can spend extra funding on. And that allows mayors, judge executives, boards of health to say, hey, well, here's some special projects that we may or may not want to accomplish. Okay. So where's this at today? Because this is all back 2019, 2020. It's now the law of the land. So it passed House Bill 129, passed in 2020. Here's what I'm most proud of. You look at the list of co-sponsors from the House, which is where this bill originated. Republican, Democrat, Republican, Republican, Democrat. So this is a bipartisan bill, despite being a very Republican-dominated legislature. I was very, very proud of the fact that we got bipartisan support for this one. There was a lot of bipartisan support going on. So we're very, very happy about that. But the bottom line is the work isn't done, and we sent you this publication beforehand. I don't expect anybody to have read it, but I just wanted you guys to have it. I was very honored to be asked to help co-author this with a lot of friends of mine who have much longer, bigger bibliographies and much more accomplished in space. But we sort of took a look at the National Academy of Medicine of what COVID-19 did to the public health landscape and the public health future, if you will, moving past COVID-19 and what that should look like. If you read this paper, you'll see basically plan I wrote for Kentucky is basically the undergirding plan of this paper of what public health should look like in the U.S. So we became essentially a national model for what it should look like. Now, we haven't fully adopted that. I will tell you that we also learned that COVID-19 sort of delayed transition of public health transformation here and abroad. So, path forward for LMPHW. There's some things you should know about how I view public health that will inform our path forward. One, I believe every Kentuckian, every Louisvillian, every Jefferson County deserves access to high quality public health, no matter where they live. I don't care if they're from Oklahoma or from the east side, it doesn't matter to me. They should all have access to the highest quality public health services. I think we got to be accountable at all levels. That means I got to be accountable. The Board of Health has to be accountable. The folks going out in our community, the nurses putting vaccines in arms, we have to be accountable. And we can't be afraid of accountability metrics. This is a big one, and sometimes is a point of controversy, especially with boards of health and some other folks. I travel the state giving this presentation, and I always get some pushback when I talk about what's going on. But I'm very, very committed to everything we do, especially in that green box, the local public health programs, has to be evidence-based and best practice. It drives me crazy when folks say, I got another big idea, or I saw something, let's jump into this, let's build a new building. Is it best practice? Is it evidence-based? And is it a public health approach addressing the issue? I don't want us competing, and I don't think it makes sense for us to compete with the family health clinics of the world, or the private practice OBGYNs of the world, or Norton Hospital. There's no reason for us to duplicate service. There's no reason for us to be competitive with the private sector. We can't do it. We shouldn't do it. But we also should be making, and our approach should be public health based. Okay. And then, like I said, the only time this becomes controversial when someone usually comes up with a big idea and I say, hey, hold on a second, that's not really a public health approach, that's a medical approach. Norton Hospital should be doing that. Humana should be doing that, not us. When I think about public health, I want you to understand that I don't think about Louisville Metro. What I mean by that is I'm thinking about what does the public health infrastructure for our region look like? And Louisville Metro Department of Public Health and Wellness is part of that, but so is the public-private partners that we have, so is the state, and so is the federal group. So when I think about it, I think, how can I shape all of these things to some end goal based on some strategic mission? So, and I think if we take that broader approach, then we got a better shot at changing the outcomes. And then finally, I believe all these issues are local, really, and if we don't tailor down to local solutions, especially in Kentucky, we're not going to be able to accomplish what we want to. Because what we need in my hometown of Harlan is a lot different than what we need here in Jefferson County. Is a lot different than what they need to do. I know we love to talk about Pikeville, Paducah, but in terms of public health, it's not the same. So the vision for LMPHW is an agile, action-oriented health department focused on preventive strategies, preparedness, and building public-private public health partnerships. Don't say that 3 times fast. No. But that's what we got to do. And if we can do those things, we will be successful. If we can do those things, we will start moving the needle up over time on public health outcomes in this community. COVID showed us agility is really important. And at the end of the day, I'm a surgeon, okay? I think and act like a surgeon, and I have a huge bias for, let's just do something, and then let's hook the patient up to the monitor and let the patient's vital signs on the monitor tell us whether we're doing good or bad. And then we can readdress. Maybe we need to think about our differential diagnosis a little different. Maybe we weren't addressing the right issue. But let's do something, and then let's come back and reassess. Well, in doing that, we'll meet our foundational needs and continue to promote equity as the top priority, one of the top priorities in the department. We're going to differentiate based off evidence-based practices, meaning we're going to look at what's available in the community, and then we're going to surveil. The issue is the last two, which are probably the most important, being able to identify community needs and surveil, require technology modernization. To agree, we don't have the funding for today, nor do we have the capacity to do. We're going to keep doing it with what we have, but if we want to do this well, which are 2 of the 4 main points, it's going to take a lot of funding. So the framework that I come up with when I was Commissioner of Health, I think still stands true today, for those green box priorities, things we want to do here that are outside core. we have to identify the need based on data. So if we decide we need a breast cancer screening program, and LMPHW needs to offer that, we need to have good data to show us that we need to do that. Our solution has to be evidence-based or best practice. We have to have identified funding streams that can be state, federal, local, or some combination thereof, or philanthropic. And then two things that really are internal to LMPHW that require a little more work on our end, but I believe are very important. For every program we offer in that green box, we've got to have a performance management, quality management plan, bottom line. It's absolutely necessary. It's the future of public health. We got to hold ourselves accountable, and it's a benefit. And then some things that give some folks some consternation and exit strategy. And this is, this is business 101, right? And in public health, we should be working our goal should be to work ourselves out of a job. We should want everybody so healthy and practicing such good health. So especially in that green box, I want us thinking about, okay, what's it look like if we don't need to offer this program anymore? Because that means we can take that funding and that personnel and transition them to a different need when you start back over. Okay, that makes sense. So internally, what does those next steps look like for me, and sort of what's the next 100 days or so at LMPHW? We got to adopt a more agile and action-oriented structure. That's fine, not a big deal. We got to advance the strategic vision through the organization, so it has to be pushed down. I want folks who are, again, nurses putting needles in arms on the ground. I want them thinking about these 5 things and how does my daily job, how do these 5 things fit? And am I meeting these needs? Am I doing all these things? Okay. We had to assess our current programmatic offerings. So Taylor is going to be leading this, but we're going to do an internal assessment of every program we offer. So basically zero-based budgeting for the business. And then we're going to evaluate all those green box, non-foundational, non-core priorities against our 5-point checklist. We're going to see where we're deficient. We're going to be deficient in some areas. That's okay. We can address that. And then we got to prioritize modernization of data, reporting, and surveillance. Those are those 2 things I showed you at the end. If we really want to accomplish our strategic mission and goals in our community, we have to be able to do that. It's going to take some serious funding to get that accomplished. So there's a couple of changes to the org chart. So as we got now, we've got a director, who has a medical director reporting on, also me, and chief of staff, Taylor Ingram. We've made the director of communications report under Taylor, just because I like to know what the messaging is. I hold that a little closer to home. So the report director, chief of staff. I did remove the director of admin, which used to report directly here. I moved that under our director of operations. So I structured this the same way I restructured DPH. Director of operations, Connie Mendel. Deputy Director of Clinical Service or Health Services. This is Stacy Ingram, who's on the call with us. And then equity, I kept reporting to me too. And equity is a bit of a challenge because it lives in both categories, really. And so really equity has to be woven into the fabric of what you do within the health department. But I really wanted to continue to promote equity at the level it is. I really wanted T. Gonzalez, who's the director there, to continue to report directly to me to make sure that vision is getting met. And then I'm probably going to make a transitional policy. I talked to T about this because it lives under him, and I talked to Rebecca Holbach, who is currently a policy person. And I probably will move that over to the reporting of the chief of staff, because being a policy nerd myself and understanding that policy is the biggest tool that public health has. So what can the Board of Health do? I think understand and promote the role of public health. What I mean by understand public health is understand that public health in itself is essentially a little different than healthcare. A lot of people think public health is the same as what U of L does in terms of the hospital or what North does in the hospital. It's a little different. And so there are certainly intersections and crossroads, but understand there's a fundamental difference and that we have to find a way to coordinate with them on our public health functions. You guys have a huge convening power and a huge amount of influence. We need you to utilize that on our behalf. And then influence both good and bad policy. You know what I mean by that? Some of it's really good. We need to promote it. Some of it kind of takes us out of that, takes us out of the sink where we can focus on our five core values, that we start using money that are not elegant, the green box priorities. Maybe folks want us to do something that's not evidence-based or best practice. Those are things we need your all's influence on. So the questions I have for you guys, and we'll address this thing. How do you want to be communicated with? Let us know what the best way to communicate with you is and on these sort of issues. How do you want to be engaged in policy and strategy? goings on in the department and how we're thinking about those goings on. And then what are your priorities? I'm not, I've talked to Heidi a lot, but what I would love to know is what are the board's top priorities and how can we fold those into our daily work? So final words, as you can probably tell, structure, candor, and extreme bias for action are sort of all the personality traits I want the department to have. IT modernization is absolutely critical and extremely funded right now. Cannot be afraid of accountability at all levels. And you guys probably got the picture. I talk fast for a Southern or Southeastern Kentucky area. When I was doing my public health, where I was doing executive training, they always told me that it might come off that I fake my accent. I was like, I can't fake an accent. But with that said, Andrew Jackson, one of my favorite quotes from Tennessee, the old hickory from Tennessee, was wrong on a lot of issues, but I love this quote. I was born in a storm, and a calm doesn't suit me. So all the changes, movement, a lot of things going on, I love those atmospheres. I'm the surgeon at heart, so the more crazy the situation, obviously, the calmer I am inside. I enjoy it. When it's too calm, I find myself distracted. That's the reason I listen to the radio, watch TV, and study all at the same time. All right, I will stop there. I hope I didn't go too far over, Heidi.
Did not. There was more put into this brief overview than is in.
So when do you want the answers to those questions?
Yeah.
Whatever you want to give them. And in whatever.
You want to go back to that slide?
Yeah. I think that board members who are here is not only this one, but but also on your vision slide where you've got the priorities in terms of and I know that people like you and I don't talk about barriers because we're barrier busters, but that's one piece that the board can do is to remove barriers that create opportunities. So I guess the net is just that. Now to this particular slide, and I'll go back to Margaret. Generally speaking, in response to the first, that generally come through through Amanda on a regular basis. And then as chair during the month, if there are issues and the board receives mailings from or emails from me with articles and Norton's Flipper from everything that I read to share. So it will go through and I'm going to say your name right. So tell me how you say it. Arlana.
Yes, ma'am.
Okay. So it will go through her and we'll get all that done. So Margaret.
Yeah, well, actually, first of all, I'd like to turn it around and ask you what you want the answer to be.
So, that sounds like something one of my kids would have done. So it's
Smart kids.
yeah. So it's always a while. So I think for me, I prefer structure, and what I would love to do is just say, hey, here's how I plan to communicate with you if it fits your all's needs. Is I will funnel my message through Taylor, who then will either send it directly or through Arlena, however Taylor wants.
So are you saying email? Is that what you're saying? In what manner do you want to be communicated?
Well, I think it depends on the urgency of the issue, the sensitivity of the issue, and there will be things that I will want to relay directly that may be off the record. And those issues, I would love to have the opportunity to call and say, hey, this is something I would like your help with or like your input on. I'm not ready to put this on the record. There will be times that I will communicate with documents that will be formally written from the director to the board, addressed in a formal memo that will just be a decision document or a document that is more formal in nature. And then sometimes I'll send prospective documents through those folks that you'll see will have pre-decisional for discussion purposes on the top. Those are information that I'm not really sure what I want to do with yet. I'm not ready for the information to be public, but I want some input on and to ask. Bottom line is the ask for me, when it comes from me, will be fairly clear. I would like to have the opportunity to interact with you guys in a multitude of ways, depending on the urgency of the issue and the sensitivity of the issue.
Okay, next one.
So what I would like to do is, I know we had the directors session. I would like to have the flexibility, either we can do it quarterly or as issues pop up, whatever you see fit, to, I don't know if it's fulfill this perspectives dissection or, and make it a, what's the policy landscape in public health looking like? There's sometimes that those sessions might, or that discussion might not be appropriate for open discussion though. So we have to figure out how to make that work, and perhaps
We will make that work in a way that meets Natalie's on, in a way that meets the law, spirit of the law.
And then priorities for you guys, what I hope those priorities are: number one, improving the public health of our community. Two, I would hope it would be data modernization because we desperately need it. And in terms of disease surveillance, we're doing a lot of cool stuff. You got wastewater going on, you got all these various surveillance models, but we do not have an overarching conglomerate, strategically aligned surveillance program, in my opinion, that provides information in actionable formats. What I mean is, I would love to have a dashboard. I would love that the Board of Health have a dashboard. I would love to be able to report to you guys in a way that's outside this, the script you guys get every board meeting. Say, here's our, I'd love to be able to pull up a dashboard and say, okay, here's where we're at COVID, here's where we're at flu, to this flu season, whatever. And have actionable dashboards that I can look at every day and say, okay, we got to make 4 decisions based off this information. I guarantee you, Humana CEO has that on the.
No, the management team does. I think that, and Margaret, I'm going to go back to you, the department in the past has requested funds, ARP money, called
Yeah.
ARPA monies, but whatever, for data systems. And I cannot think of a higher need than to take an archaic system and have it work in Jefferson County, because we know the state system, trying to think of a nice technical term, doesn't work. So I guess, where are we? Where are we on that?
I think I know the answer to that.
I want Connie to chime in after I give some overarching comments. So here's what I can tell you from my time at the state, my time here so far, is that we tend to talk about data modernization in terms of EHR. And EHR is not the end all be all. And frankly, in terms of public health, EHR, in my mind, is lower on the priority than a complex serviceable. There's a service contract that goes with it. Data analysis, real-time data analysis program that include, and I'll put my epidemiologist hat on, that sort of can give me real-time models that can be edited and remodeled in real time to address certain needs and new variables as they come up. The issue is this keeps getting funded at meager levels across the board. So we'll get, whatever, I think Little Metro would be getting $1 million or so a year. The state had gotten like $1.4 million a year. I think the state got a $6 million one time, then pulled some general funds to a total like $8 million. And then they've had $1 million of funding a year to do a statewide EHR. It's just, it will not work. And we keep wasting not pennies, but 10 cents on the dollar, as opposed to finally just saying, hey, we're going to make an investment in this and get it done. That's the issue as I see it. I think what's convoluting us now in the discussion we were just recently having is what EHR looks like. And I think it's appropriate for me to say this on the record, is that traditionally Louisville Metro has been getting from the council about $1 million a year, maybe a little more than that, to help fund an EHR. And we're currently in the bid processes. Don't let me say anything I shouldn't about that. But the issue, $1 million, we will get some rudimentary system, but we're not going to get the bells and whistles. It may or may not, if the state adopts something, it may or may not communicate with the state's program once they get it, which may mean where data is isolated from everyone else. It may or may not be able to function with universities, Epic or University Cerner and their outpatient Epic, Norton's Epic, and then whatever our family health centers and other folks in the community are using. So those are the issues that we have. That's the landscape and the barriers that have to be overcome. Those are all solvable problems. The technology exists, the people exist who can do the job. It just costs a lot of money. I've never had enough support to make that happen. What has made this more complicated recently is I didn't realize this, and it was just me being out of touch with the state budget for a year, is that I think the state budget has quite a bit of money in it next year, and we're sort of figuring this out, like $20 million to help fund an EHR. That may sound good, but I'm just going to tell you, when I was state health commissioner, Tennessee adopted the VA CPRS system, which the VA is getting rid of now, which was built in the 80s, so it was archaic in 2017. And they cost them $30 million out front to roll it out in all their health departments. And remind you, this was a pure VA medical EHR. It's not a public health record at all. Doesn't include some of the, it wouldn't have the ability to take our wastewater data and incorporate, things like that. So it's an expensive endeavor. The best outcome, in my opinion, would be a statewide public health data and analysis program that then allow us flexibility at local levels to get extra funding, add on to it, build out from it. But it will require coordination between state and locals at a level, state and local governments at a level that's never happened, and a funding stream to a level that we've never even thought of before. $75 million statewide. Got any comments, guys?
Yes, let's put one of the agreements on for a couple of minutes after this meeting.
And say, I would say the third priority that I would hope the board would have, so the first two being for the public health, 2, data modernization, 3 will be supporting us as we adopt that framework which I laid out around local health priorities, which includes make sure they're evidence-based, that we're not overextending ourselves, that we're prioritizing, and that we're using that checklist of 5 things as we consider.
Let me go to questions from the folks on the phone. Dr. Eccles, questions? I can't, I think you might be on mute.
Can you hear me?
Yes, now I can.
Okay, I apologize. I don't have any specific questions right now. I think that the questions that have been posed are important, and moving forward, the biggest thing, at least for me personally, I think will just be how we'll get our communications. And so I personally don't have a preference. You can send an owl, tweet me, call me, text me, come by the house, whatever. But I think that I'm excited for us to move forward. And as questions develop, I will be very happy to share them with the group.
And Dr. Eccles heads our immunization. Ms. Haskell? Okay. Anyone else on the phone? Am I missing anyone? So, Nat, thank you.
Another question.
Sorry.
Where does behavioral health fit in your thinking around this? As I look at public health broadly, and even in some of the overview papers, it seems to be sort of a stepchild and an afterthought, even though we recognize at a whole nother level the number of deaths associated with behavioral health conditions, shortened life expectancy associated with social instability. It always seems to be the stepchild.
So I think that's an excellent question and excellently framed. So I will say first, undergirding MOL's public health initiatives is some woven fabric of mental health. It just has to be. And the population we serve is unfortunately extremely afflicted with mental illness, is what you're sort of getting at. Now, I will say that the medical management, seeing the patient, making a diagnosis, and delivering mental health care, whether it's counseling, whether it's antidepressants, whatever that is medical system proper. So you'll hear me say a lot over the, however long we work together, that there's public health and then there's medical proper. And I sort of push them apart, but there's a big overlap. And I would say that's medical proper, that's the medical system proper. And in the public health system, we have some overarching hands and fingers that go into that area. I see our role primarily being one, identification, so that surveillance role. And what I mean by that is knowing what the risk factors for mental health are, the signs and symptoms. And when we see patients, which we're going to interact with folks who are going to be suffering those conditions, navigating them to the correct place. And I think that's our primary role, whether that's in our syringe service programs, where we see folks coming in who actually need to go, need to get help elsewhere, or say to us, hey, I actually want to go to, a mental health provider or or want to get MAT now. We make those referrals. Whether it's our outreach, maybe we're doing a vaccine program in our homeless camps, and it's navigating those folks to the proper facilities, whether it's U of L, whether it's whatever that may be. That is primarily our role. What I don't ever see us doing on the extreme end is employing mental health practitioners to go out in the community and hear it.
Yeah, I'm thinking more policy oriented than that. What's the role of public policy, for example, in reducing social isolation? There are some public health departments that have specific policies associated with building deeper fabric in the community for connection, more social capital in the community. And I think those are public policy discussions that appropriately connected to public health.
There's certainly no doubt that there's a policy side that public health has a role in, because healthcare policy does follow public health to a large degree. And like I said, I think policy is our most important tool that we can utilize, and we have to value it to a greater degree. And that's the reason I wanted to make a little transition in the department in terms of the policy approach. But, I think what you're sort of getting at is, should the public health department be encouraging policy to improve mental health? The answer is yes. And when we see those policies come up, we should be helping support those. I think the broader question is, what happens with those policies? Because most policies are going to say, okay, we recognize mental health as an issue, or social isolation is an issue in our community. Then when those policies are enacted, what's that policy read? It's going to be, we reckon, where the local metro council recognizes there's a isolation issue in our community, therefore the health department shall do X, Y, and Z. Okay, and that becomes a mandate that then we have to perform. And then, in my mind, that's the green box priority.
So, are policies that department should examine. I think we should, just share with me, and I'll get them to the department. I think that may be the best route in terms of ensuring, given this time, and I want to be able, quite frankly, to move on so that we can get some other folks in this discussion, one being Eva Stone, the health director for the school system, and also I think Angela Hayes is on as well. There she is. Because in the schools, we also have the issue of mental health isolation and all that went on in the homes, et cetera. So let's take a look at what we can do there and what we can do with the council. Does that sound good to everybody? And I hate to stop this discussion, but I'm going to, because I'm recognizing people's time here. Any final words from anyone? And we expect something similar to the next meeting as well. Thank you very much, and thank you to and welcome to the new members of the department and to those returning. Let me, for my part, there is nothing other than what was in the document, the update that I sent you in terms of my report. I think given this meeting, given summer, we will clearly move to virtual only for the summer, which is, I know I've flip-flop back and forth, but that notice will be sent out several times so that we know and it's easier for people. I originally thought it might be good to have the candidates here in person, but I think given the spread of COVID right now and everything, we'll just be virtual. That's okay. Now, the chair is, let's see, Ms. Mendel, is there anything urgent from the department? Okay. So the chair recognizes either Eva Stone or Angela Hayes for a health update from the Jefferson County Public School System.
I'll just say, and then I'll let Angela talk about, it's exciting. We did our first VFC clinic last week. So you all know and have been a great help in helping us become VFC providers and get rolling on that. The only thing I'll say is, as we've discussed, we have been working really hard on making the COVID vaccine accessible with the significant health disparities. And as I've mentioned, we have, some of our schools have 7% of children vaccinated against COVID versus 84% at other schools. And so the disparities are very significant. You mentioned electronic health record. That's been one thing that has been invaluable for us to be able to do COVID monitoring, surveillance, and a deep dive into our vaccination rates for COVID. So you all funded the first year of that, and so that has been very, very appreciated. We've done over 10,000 vaccines at school located clinics, but we still just have about 33% of our students fully vaccinated. And so it remains citywide, that is lower than what the citywide average is. So again, our children living in poverty, it's been a real issue. So we'll be revising our COVID plans for next year. What we have is in place until the end of June, and then the board will talk, the board will make decisions about what things will look like moving forward. And then I'll hand it off to Angela to talk about her great work in the VFC program.
And just one question here. Don't think I received a copy of the vaccination by, especially interested in elementary school, where the disparities are. If it could go, if somebody can send me that, that would be great, because we can certainly get the people who live in those districts, if possible, who are board members to outreach, as well as probably some members of our community advisory board.
Yeah, and I want to say your team, we've met to discuss, they've been very supportive in us getting together, brainstorming and looking at options for moving forward. And again, we've been working real hard to connect every school with someone who could give vaccinations. So our primary goal has been connections with the community health centers, but that's just been a slow moving process.
So Dr. Irwin is here. Any comments, Dr. Irwin, from Family Health Center?
Yeah, I think employee capacity probably constrains us the most. We're still struggling with the maintaining and hiring employees.
Okay, so the point that he was making for those on the phone, if you did not hear, is the constraint of staff being able to administer. So if you know that Ms. Manson is on, I know that others are on, if you can help out in some way, just let me know. That would be greatly appreciated.
Ms. Manson was part of our meetings with your health folks. So we're already working on some vaccination strategies that the Kentucky Nurses Association will be involved with.
Perfect. They are everyone's fairy godmother.
And I will say too, you know, you all have heard me say Newcomer Academy is one of the most concerning sites that we have, which is where all immigrant and refugee children who are middle and high school age go. And that's the school where less than 40% of students even have an immunization certificate. And so it's been a high priority for us to try and get a school located clinic there. We've just not had any success. So what we'll be doing next year is rotating our nurse practitioners. We'll have a nurse practitioner there every day of the week, really for physicals and immunizations, but we've got to work on some strategies to get kids connected to a medical home.
Okay, Angela, any other comments?
Yeah, just to talk about how we expanded our access to COVID-19 vaccines. We're also trying to expand access to all immunizations. So as Eva said, we started with a small kind of pilot vaccine clinic at ESL Newcomer. And we have our own vaccine supply, VFC supply now. So that was very exciting for us, but we have one immunization clinic under our belt, and we are hoping to just expand those efforts this year. To all, we want to improve access to immunizations and healthcare to all of our students. There's a huge disparity with that throughout the district. So we are really working hard towards that.
If you all need help, you know who to call. Okay, thank you. Let's see, where are we? Dr. Valerie Brion's prior could not be here as one of her colleagues is out with COVID, so she had to take that physician's patients, not familiar Zoom, and said there was no update from the Greater Louisville Medical Society. Ms. Manson from the nurses.
Good morning. Just quickly, we did our last vaccine clinic for the health department last month in May, and our volunteers are really sad. So we are excited about helping out with the Jefferson County Public School System and any other clinics where we might be of service. We want to keep our volunteers engaged. We worked hard to get them, and we'd like to keep them. I am meeting with the health department on Monday, including Ms. Ingram, who's going to help me to keep our people engaged. We started our CE classes on wellness, which includes suicide prevention for nurses and implicit bias training. It's open to any healthcare provider or anyone who wants to take our classes. They're on our learning management system. And we, as the nursing profession, just released a 6-part series of reports on racism in nursing, and that is available to anyone who wants to read that. It is a public health crisis, and we are going to need to address that.
Thank you so much, and thank you for your service and extending the vaccination to preventive immunizations for the Jefferson County school systems is absolutely critical, beginning with those who are not at, in a lower percentage of being immunized. And it prevents something future that could have been prevented. So, Greater Louisville Inc. How are you?
Good morning. How are you? Don't have a huge update. A couple things coming up that I wanted to make you all aware of. Our legislative outcomes document from session should be released today. Hopefully, fingers crossed. So take a look at that, at some of the health bills that we followed during session. At the local level, we are hosting a mayoral candidate forum on June 14th. As you all know, GLI does not endorse candidates, but we do educate. We did a candidate survey a couple months ago before the primary, and now we're going to do this mayoral candidate forum. So hope to see you all there, and everyone knows the importance of this race and getting our priorities passed. So we're excited to host the forum. And just as session is, over now, we're already preparing for next session. So our state and local legislative agendas, we will be starting the process on those for next year in August. So if you're a member of GLI and not on the healthcare committee, Just really encourage you to get involved so that we can make sure your priorities are included in our agenda for next year.
Thank you so much. Appreciate it. And encourage everyone to, if you are not, have not been to a candidate perspective session, to take advantage of GOI. 2-minute update immunization. Dr. Eccles.
Yeah, we don't have a very too terribly big update either. With our last meeting, the immunization committee discussed focusing our efforts on talking with people in the policy space. So kind of trying to going back to the goals that we set several months ago, looking at ways that we can kind of help the Kentucky immunization registry be more prevalently used and easier access by a wider base of providers within the community and kind of more streamlined. So we are hoping to have some discussions with policymakers and some key stakeholders at our next meeting, which will be next Friday, the 10th. And so moving forward, we are just trying to kind of refocus our efforts a little bit on how we can be more involved with policy changes, or at least speaking to policymakers about the Kentucky immunization registry and kind of aligning that as one of our main priorities.
Thank you. This one has bugged me. That was a public health term, I'm sure, but in Ms. Mendel's arena in terms of bugs, but it's a nit. I am going to ask Taylor to get with you, Dr. Eccles. I'm tired of the Kentucky immunization registry because I think they have not expeditiously resolved the issue that they have, and it's not useful. And it also requires somehow our getting out to the pediatric specialty group and others to make use of it and to get their data into the system. So not being a clinical person, I don't know how that occurs, but if we can smooth the pathway, and Dr. Howard, I give this to you as well because they're your medical colleagues. But this has stalled, and the state's not going to solve it. We're going to have to solve the input here. And anyway, if you all can get together, that'd be great. Thank you. Dr. Irwin or Ms. Shoemaker for the coverage hour.
Sure. Our next meeting is scheduled for June 13th. It will be a virtual meeting at 4 o'clock. HHS is likely to extend the federal public health emergency at least one more time through mid-October, which means that we are still not seeing people falling off of Medicaid, and we are still seeing a pause in Medicaid renewals. So we are working to get the message out to Medicaid members to make sure that they keep their address and contact information up to date on the Connect system so that they can receive any correspondence from the state when the PHE does end.
Great. And thank you for your continued work in this area because it clearly makes a difference in terms of coverage for those most vulnerable. Dr. Zippel, a minute or so on the Behavioral Health Committee's a couple projects.
Right, a minute or so, 3 points. Number one, the diversion project and evaluation with 911 looking for mobile response and respite as opposed to police response. Report is due to council in the next 10 days
Yay.
or so. So after council receives that, then it goes through committee, it'll be available here. So certainly by the July meeting, it should be able to be distributed here.
Perfect.
It is on the budget for council to extend the program for the next fiscal year, including the evaluation. We'll see how that goes. With regard to the ACES project, I have a meeting tomorrow with somebody who has interest in serving as a project lead. With that, third point, the Behavioral Health Committee has become a committee of one. And it's hard to run a committee that way. I would love to find a couple of partners in crime for it. So if folks have an interest in that area, let me know.
Perfect. I shall help too. Is there any new business to come before the board? Any comments? Any announcements? Okay. The next meeting of the board, it will be July 6th. It will be virtual. And for the next two meetings, both July and August, we will have the Republican candidate for mayor at the July meeting, and that's Jeffersontown Mayor Bill Dira. And we have asked each of the candidates, so beginning with Bill, in July, to talk about their public health priorities and then their other priorities. So I encourage everyone here, and I'll be in touch with the remainder of the board and our community advisory board members to begin thinking about those issues that are important to ask the candidates. So we'll have our own internal session with them. In August, Craig Greenberg, attorney, entrepreneur, will share his views. He is the Democratic candidate for mayor. So we will have an opportunity in separate sessions to share our views with them and to hear theirs regarding how we move this community forward, both in terms of improved outcomes and in terms of positive system change, both on an equitable basis. Anything else from anyone? Both July and August are virtual. Great discussion today. Thank you again, Dr. Howard. We stand ready to do our part, extend our hand in partnership, and help you overcome any barriers to the opportunities ahead. So, the chair will entertain a motion to adjourn.
So moved.
Is there a second?
Second.
Then we can have discussion. Anybody want to stay here? I want everybody to go out and help make this community healthier. How's that? Please stay and be well. Remember to mask up in groups. We will see each other online next month. This meeting stands adjourned, and I thank anyone else out there as well.
So this is a tomorrow issue, so can we talk?
Let's just wait.